Hello everybody and welcome. So my name is Dr. Amber. I'm going to be talking to all of you today about delegation and assignment making. That way, when you see these items on NCLEX, you are very well prepared. So I'm going to give everybody another minute or so to get logged in. So while we are waiting for everybody else that's going to join us, I want to know, where are y'all joining us from? Oh, and I also want to tell everybody before I forget, there is a little bit of a chat delay. So anytime you leave a comment, it does take a little while before I'm able to see it. So I'm never ignoring y'all. So I am from Texas, if you can tell from the accent, which you probably can. Israel, that's awesome. Detroit and Ohio. I love to see where everybody is joining us from because it's so cool to know that this is being streamed internationally. Nigeria, awesome. Well, I know many of y'all are preparing to take NCLEX very soon, so my hope is that this webinar helps you a lot because you're going to hear me say this a couple of times. You are guaranteed to see delegation on the NCLEX exam, so this should certainly help you. Also, if you have any friends or peers that you think would benefit from this, share the link so they can join us too. And this also is recorded, so you can watch it at a later date. So let's go ahead and get started. So before I do, I want to remind you guys, we have a very active Facebook study group. So please certainly send the link, invite your friends so you can stay up to date on what webinars we have next. We typically do a weekly webinar on many different topics. So today, throughout this presentation, we're just going to talk about the general principles of delegation and assignment making. We're going to talk about what the nurse's role is in delegation and also discuss a couple of resources that we should be thinking about anytime that we are faced with delegation questions. I forgot to introduce my moderator. Miss Miriam is in the chat. And she is also a wonderful nurse educator that's going to be answering any questions you guys have throughout this presentation. And once again, there is a little bit of a delay, so she's not ignoring you if it takes her a second to answer you. Okay, so back to the presentation. So the reason we think it is so important to talk to you guys about delegation, assignment making, and prioritization is because when we look at the NCLEX test plan, we can see that management of care is 18% of the exam. So it is the largest percent of the exam, even more so than safety and infection control. So that means when you go to sit to take the NCLEX, it's a guarantee that you will see those types of items. You will see delegation, you will see prioritization. So once again, guaranteed on NCLEX, and I want to remind everybody that when we're talking about delegation, that's not simply asking somebody to just perform a task for you. It's a very complex nursing skill that you really need to know, not only for the NCLEX, but for practice. Because as you all know, when you go to the hospital and you see those nurses, it is one of the most commonly used nursing skills. But if we do it incorrectly, it can get us into a lot of trouble. So we want to make sure that we really know what we're doing so that we can delegate safely. So I want to go ahead and let y'all know 2 helpful tips that's going to guide you throughout this presentation and whenever you're practicing delegation. The first one is we don't ever want to delegate tape tasks. Those are things that the registered nurse is responsible for. It includes patient teaching, assessment of your patient, developing the care plan, and evaluating the patient's care and their response to interventions. So those things we do not want to delegate. And also, I know you already know this, but I want to remind you guys, we never want to delegate tasks on unstable clients, okay? So we want to make sure we are only delegating for stable clients. So there are a couple of resources that can help guide us whenever we're navigating delegation questions that we really want to be familiar with. The first one is the provider scopes of practice, and the second one is the 5 rights of delegation. So let's look at those really briefly before we jump into some practice questions, which I know is what you guys came for. So the scopes of practice is just understanding what is it that our peers that are working on the unit with us can do. What is in their legal scope of practice that's safe for them to perform. So let's start with the UAP. The UAP has the smallest scope of practice, and I will tell you, most NCLEX questions on delegation are delegating to that UAP, okay? So the UAP can only ever perform care on stable clients. They should never complete any type of tape tasks. They should not perform any part of that nursing assessment. That is outside their scope of practice. And they are typically responsible for performing routine and non-invasive tasks. So when I say that, I'm talking about vital signs, hygiene like oral care, pericare, and once again, it's only for clients that are stable. And then there is the LPN or the LVN. That is the same role, but it's just different names depending on where you live. So LPNs, you won't see these questions as often as the UAP, but they can be a little trickier because their scope is a little larger than the UAP. However, the LVN can only care for stable clients, just like that UAP. LPNs can perform parts of the nursing process, but it's only after the RN performs them first. So they are able to help with reinforcing teaching after the RN has already provided it, and they're able to help monitor assessment findings after the RN has performed the assessment. So I know it can get a little tricky, but remember, when it comes to the nursing process, the registered nurse always has to perform that task first. And they can also administer medications, but it really depends on where you live, so you don't see those questions as often, but they are able to typically administer oral medications, that kind of thing. And then there's the RN, and we have the largest scope of practice. We are able to care for stable or unstable clients, and we are responsible for all steps of the nursing process. So the assessment, the planning, the evaluation, and once again, we should always be performing it the first time. And we also can do any tasks that are invasive and non-routine as well as routine tasks. And an example of invasive tasks that the RN might perform include hemodynamic monitoring and then also titrating like cardiac drips in the critical care unit. So hopefully that gives you just a brief summary of the general scopes of practice. Now, don't get too confused. I know I was an LVN, and I know many of y'all go to the clinical setting and see nurses, and you don't always see people following their scope of practice. But remember, this is what is accurate and appropriate when you sit down to take NCLEX, not what you necessarily see in the hospital or the clinical setting, unfortunately. Okay, so before we jump into questions, I want to show y'all one more thing. The 5 rights of delegation. So basically, this is just 5 questions that we should ask ourselves before we delegate a task. So the first one is the delegatee or the person that I'm asking to perform the task competent? Do we think that they have the appropriate knowledge and training to safely perform the task? And then we have to ask, is that task routine and within their scope of practice that we just discussed? And then we always need to make sure that that client is stable. Now, one thing I want to remind everybody about is we typically use delegation the most when we're very busy. However, that RN is still responsible for supervising. So the RN can't delegate a task and then leave the unit. That's not safe. The RN needs to be readily available to assist and to follow up on that task. And we also need to make sure that the delegatee has very clear instructions on when to perform the task, how to perform the task, and any information that they need to report back to you. And then lastly, as the registered nurse, we should always be going back after a task is performed to make sure the patient tolerated it well and that everything went as planned. So once again, these 5 questions kind of can give you a framework. So when you're thinking about if a task is appropriate, these are the kind of things you need to be thinking about to help guide you. Okay, so without further ado, let's go through a couple of practice questions and apply all that stuff that we just talked about. So the first question says, the registered nurse is supervising UAP. And once again, this is really the most common way I've seen NCLEX questions on delegation formatted, where it's the UAP we are delegating to. So which task would be most appropriate for the nurse to assign to a UAP? And our options are perform incontinence care for a newly admitted client who has a cervical spine injury, assist a client who had an above-the-knee amputation 2 days ago into the prone position, reposition a client with increased intracranial pressure who has decreased level of consciousness, and the last option, demonstrate use of continuous passive motion for a client who underwent a knee replacement. So let's look at each option a little more closely. So performing incontinence care for a newly admitted client with a cervical spine injury. So what do we think? Yes or no? Should we delegate this task to a UAP, an unlicensed assistive personnel? I know a lot of y'all are guessing option 2 already. We'll see. I always say that there's just as much knowledge to be gained from incorrect. So let's see if y'all are right. So option 1, I do not think it is appropriate to delegate this task. I agree with you guys, and let me tell you why. If we just see the words incontinence care, that seems like a routine task. And that's why it's very important that we don't just latch on to certain words. We have to look at the whole context. It's very important anytime you're sitting down and practicing questions or taking the NCLEX. Look at the whole content. So this is newly admitted client. So any client that is newly admitted is considered unstable because it is assumed that that registered nurse has not yet been able to perform a thorough assessment on that client. So that's a helpful NCLEX tip. Anytime you see newly admitted client or a client that just returned from a procedure, that is considered an unstable client. And remember, we don't ever delegate on unstable clients. But also, there's another learning opportunity here for us in this option. Anytime you have a client that has a spine injury and you need to perform incontinence care, that is not really a routine task. There is a special technique we use. I'm sure many of y'all are familiar with it, the log roll technique. So if we don't turn that patient very carefully with help, we can make that spinal injury worse. So that's really a non-routine task. And once again, our client is unstable. So I agree with you guys. I don't like that idea. So you guys love option 2. So let's see if y'all are correct. So assist a client who had an above the knee amputation 2 days ago into the prone position. So AKA 2 days ago. And I'm sorry, my handwriting is not the neatest. So we can assume that a client that had a knee amputation 2 days ago is probably pretty stable. And so we're just being asked to reposition them into the prone position. So do we like this idea? Yes or no? Are we going to delegate repositioning this client? So I agree with you guys that this would probably be appropriate to delegate, but we haven't looked at our other options. So this client, once again, had surgery 2 days ago, so chances are they're pretty stable, and all we're doing is repositioning them, which is a routine task. Now, bonus question. Why would we even reposition a client after an above the knee amputation into the prone position? Does anybody remember that? It's a little bit more challenging. Winnie, you said past 12 hours post-op are considered stable. Yeah, that's a good rule. Typically after that first 12 to 24 hours or so, that client is considered stable. So we want to prevent contractures. So placing a client that just had a knee amputation a couple days ago into the prone position, we're going to typically do that a couple of times throughout the day to prevent contractures. So great job, Leah. I'm super impressed. That was a bonus question for you. So once again, I like this, but let's look at our other options. So option 3, reposition a client with increased intracranial pressure who has decreased level of consciousness or decreased LOC. Do we want to delegate this? So I feel like most of y'all are going to tell me no, and I'm going to agree because we have a client who seems pretty unstable. Okay, decreased level of consciousness is typically not a good thing with any client. That is an indication your client is unstable. But we're also concerned because this client already has increased intracranial pressure and we are repositioning them. So what happens if I have a client with increased intracranial pressure and I position them incorrectly? Maybe I lower the head of the bed or I even place them in a supine position. What's going to happen? Anytime you have a client with increased ICP and you place them in a supine position, or lower the head of the bed. What happens? And once again, there is a chat delay, so I'm sorry. It takes a little while for me to see your answers. It's going to increase that ICP more. So I can actually make that client a lot worse. So that is certainly, like I said, an unstable client. So we are not going to delegate that. So let's look at option 4. Demonstrate use of a CPM device, or continuous passive motion device, for a client who underwent a knee replacement. So that seems pretty simple. So do we want to delegate that? Yes or no? So I'm not going to delegate that, even though it sounds simple, because the words demonstrate use are just another way to say educate. Okay, so very good, Winnie. Teaching, yes. So we cannot have the UAP performing steps of the nursing process. They cannot do client teaching, because remember, that is a tape task, which UAPs cannot do. So that teaching, okay. So we got that correct. So awesome job, guys. And I know that was a little bit of a simpler one to get you warmed up. So now I want to go ahead and do a little bit more challenging one, a select all that apply, which I know is everyone's favorite. But we're just going to take it line by line, like a true or false. So the nurse is caring for 5 clients on a telemetry unit. Okay? Which of the following client needs can the nurse delegate to a UAP? So once again, we're talking UAP. So the first one, determining the pain level for a client that just received IV morphine. Just received. So what do we think? Yes or no? Do we want to delegate this to a UAP? Yes or no? Determining the pain level for a client that just received IV morphine. So I do not like the idea of delegating this. Just like Linda, Winnie, I agree with all of you guys. Or false. Sorry, Dee Dee. Here I said we were going to treat it like a true false. False. So determining the pain level for a client that just received a pain medication is evaluating their care and kind of doing an assessment. So that is, once again, a tape task that we are not going to delegate to a UAP. Option 2, assessing a client's ability to swallow food prior to feeding them lunch. So this one is a very, it's easy in my opinion, only because the word is assessing. Right away it tells you that's a tape task, that's assessment. We're not going to delegate that. But also, if we're checking if a client can swallow food before feeding them, that is certainly something that we don't want to delegate, because if that client does have dysphagia or difficulty swallowing, we can cause them to aspirate and have a lot of complications. So no, I agree with you guys. Option 3, assisting a client admitted with pancreatitis to ambulate to the restroom. So remember, pancreatitis is just inflammation of the pancreas. You typically have some nausea, vomiting, you can have dehydration. Manu, you said, what's tape? So tape, you might not have been here for the previous part, so I just want to remind everybody, tape is those steps of the nursing process we're not going to delegate. So that is going to be teaching, assessment, planning, and evaluation. Great question. So I see a lot of yeses for option 3, and I agree with you. There is nothing in that option that indicates that that client is unstable. So it's just a routine task to help somebody ambulate to the restroom, so I love it. Option 4, assisting a client admitted with a myocardial infarction to perform oral hygiene. So a client with MI to perform oral hygiene. Do we like that? What do you think? And this is where I'm going to give you another helpful NCLEX tip. Don't overread, okay? Don't read into the question. I used to do that as a student. It's very easy to do, but don't do it. Because you could say, oh, myocardial infarction, that's a serious diagnosis. Maybe they're unstable. No, we're not going to go down that rabbit hole. We are going to just look at what they tell us. So I agree with you guys. That is a routine task, oral hygiene, on a client that is stable based on the information we have. Option 5, performing pericare on a client with an indwelling urinary catheter. Yes or no, or true or false? Do we want to delegate this? yes, I agree that that is perfectly fine. Pericare is a routine task, and I know the client has an indwelling urinary catheter, but there is nothing to indicate they are unstable. So I think that is safe. But let me give you an example of when that would be inappropriate to delegate. Maybe it says perform pericare on a client with an indwelling urinary catheter with blood at the urinary meatus, or maybe they have bladder distension. Those are all indications that our client is unstable and we would not want to delegate that. So option 6, recording the intake and output of a client with a history of CHF. Do we want to delegate collecting intake and output of a client with CHF? What do you guys think? So I think that is also a good option, just like you guys, because once again, intake and output is a routine task, and based on the information we have, this client appears stable. So let me give you another example of when this would be inappropriate. Maybe we have recording the intake and output of a client with a history of CHF with pink frothy sputum, or with crackles, or edema that's 4+. All those are indicators that the client might be in fluid volume overload or have pulmonary edema and would not be considered stable. But once again, we're not reading into things, so I agree with you. And then last one, this one kind of tricks people up a little bit. Performing vital signs on a client that just returned from the cardiac cath unit. So the cath lab. What do we think? Do we want to delegate this? Because a lot of times people see vital signs, and that's one of the most common tasks that's delegated. So they see that word, vital signs, and they just want to say yes. But y'all are on the right track. Lindy, Manu, Winnie, great job. No, because once again, as we said on the previous question, just returned or newly admitted or newly arrived, all of those tell us that that patient is unstable, and we are never delegating on an unstable client. So options 3, 4, 5, and 6, and we got them correct. I'm super impressed with you guys. Y'all are doing an amazing job. So let's do one more question, but let's change it up a little bit. So the last 2 items were delegation, so let's try assignment making. It is not as common, but there is a chance you still may see it, and I want you guys to feel confident when you do see an item like this potentially pop up on NCLEX. So instead of delegating, it is making safe assignments for a client. So a charge nurse is making client assignments for a critical care step-down unit. Which client would be most appropriate to assign to a new grad RN? And I know some of you might be thinking, well, we just talked about scope of practice, and the RN can care for any patient. And you are right. But remember, we are at that magical NCLEX hospital where staffing is perfect and we can be very selective. And so we want to give that new grad a very stable patient with a simple care plan, okay? Even though they can care for any of these. So option 1, a client admitted for diabetic ketoacidosis on an insulin drip, a client who is scheduled for discharge today with a new colostomy, a client scheduled for a pacemaker insertion procedure during the shift, and a client admitted for postoperative infection who's receiving IV antibiotics. And I know a lot of you guys are making some great guesses right now, so let's talk about each option in a little more detail and tease out some more learning. Option 1, the client admitted for DKA that is on an insulin drip, which means IV insulin. So why would I not want to give that to a new grad? Because I didn't see anybody guess option 1. It's because that client with diabetic ketoacidosis typically has a very complex care plan, especially if they are still in an early enough or acute enough phase to require IV insulin. It's typically going to be very frequent glucose checks, hourly or more frequent, and they are getting IV insulin, which is one of the most high-risk drugs we can give, okay? If we accidentally bolus insulin, there's a good chance that we can that patient can code. So that is a complex care plan that I would really ideally like to assign to a nurse that has a lot of experience administering IV insulin and caring for clients with DKA. So option 2, a client scheduled for discharge today with a new colostomy. Okay, So discharge today sounds pretty simple, but I didn't see a lot of people guess that. So why do we not like that option? Well, when a client has a new colostomy, that is going to require a lot of client education. They need education on site care to prevent infection, excoriation, but also a lot of psychosocial and discussion of lifestyle modifications and that type of thing. So ideally, you want to give that to a nurse that has a lot of experience with colostomies, wound care, that type of thing. So I agree with you guys. Option 3, a client who is scheduled for a pacemaker insertion procedure during the shift. And I didn't see a lot of people guessing option 3 either. Why? Why would y'all not want to assign that to a new grad nurse? Client going for a pacemaker. Well, when a client returns back from their pacemaker insertion, we have to very, very closely monitor their cardiac rhythm. We have to make sure everything's working properly, make sure that they have adequate perfusion, and a lot of things can go wrong there. So you really want a nurse that has a lot of experience with cardiac rhythm interpretation or ECG interpretation. So ideally, you'd probably want a more experienced nurse if you can. And y'all are correct. Y'all also said that there's a lot of teaching associated with the surgery, and that's true too. A lot of times patients will have a lot of questions before and after surgeries. And then the last one, y'all all love this, and I agree with you guys. The client admitted for a post-operative infection who's receiving IV antibiotics. Ideally, that is a very simple care plan and will typically just require monitoring vitals, administering antibiotics, that type of thing. So I agree with you guys. But let me give you an example of when maybe that wouldn't be the best client. Maybe it says a client admitted for a post-operative infection receiving IV antibiotics who now has tachycardia, hypotension, elevated lactate levels. What would that indicate? Somebody that has an infection who now is hemodynamically unstable. They're tachycardic, hypotensive, having an elevated lactate. Can anybody tell me, bonus question, what you would be worried about if that was your client? What do we think? So I'm going to be worried about sepsis. So in that case, I am not going to want to give that to a new nurse. Okay, and look at y'all, Stephanie. Awesome, very good job. Shock, Mary, yeah, septic shock, same principle. Very good, guys. So we got that correct as well. So once again, and if y'all have any questions, once again, there's a little bit of a delay, so feel free to type in your question, and I'm just going to briefly recap what we talked about. So I want you guys to keep practicing delegation items because they are guaranteed on the NCLEX. Remember, NCLEX is a safety exam, and delegation is one of the biggest safety issues that nurses have to deal with. So keep practicing delegation, get comfortable with it, look at your 5 rights of delegation, make sure you feel comfortable with the scopes of practice of the UAP, the LVN, and the RN. And then remember, we never delegate our TAPE tasks, our nursing process tasks, such as teaching, assessment, planning, and evaluation. The registered nurse needs to do those, especially initially. And then remember, we are not delegating tasks for unstable clients. They must be stable for us to delegate tasks on them. Okay. I also want to remind you guys that at bootcamp.com, we have some wonderful cheat sheets. We've been hearing some great feedback from students on these, where we've pretty much consolidated all the important things you need to know about delegation into this cheat sheet. And there is additional information that we did not discuss today, such as this delegation flow chart that will really help you. So please go to bootcamp.com and check that out. So here's our website, and also remember to follow us on socials if you have them, and share us with your friends and your peers. So let's see what kind of questions we have. Lakita, where can we find more delegation questions? Okay, so bootcamp.com/NCLEX. We certainly have a bunch of delegation items there, as well as additional assignment making questions. Okay. Well, I thank you guys so much for joining us. I hope you'll join us next week for our next webinar, and I hope you guys have a wonderful rest of your day.